This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this very special installment of the Practice Perfection web-based education series. Today's presentation is entitled Sex, Drugs, and Oral Cancer. Recent trends in oral cancer have heightened the importance of a proper oral cancer screening protocol for all medical and dental professionals. The incidence of oral cancer has increased each of the past 7 years. This deforming and sometimes deadly disease is now affecting patients with no traditional risk factors. Owing to the 225% increase in HPV-related oropharyngeal cancers, oral cancer is occurring in younger populations, changing the perception of who is an appropriate screening candidate. This strongly suggests the need for a new adjunctive oral cancer screening protocol. Today's webcast will introduce recent and emerging technologies for the early discovery of oral cancer, including fluorescence technology and quantitative cytology, as well as their proper implementation. Clinical examples of these procedures will be presented. As cancer therapies continue to evolve, two oral health concerns from many such treatments are xerostomia and mucositis. Other common side effects and treatment options for the oncology patient are covered. Our presenter, Robert Whitman, is a graduate of Tulane University with a BS and MSE in biomedical engineering. He brings a unique mindset to the medical device industry. As a clinical engineer at MD Anderson Cancer Center, Robert had a passion for early cancer diagnostics. He joined the R&D team at a private startup developing cancer screening products using fluorescence technology licensed from MD Anderson, and later co-founded Forward Science LLC, a medical device company established with the goal of advancing oral health care through early discovery, diagnostics, and treatment options. He is now their CEO and speaks on the topics of oral cancer and early discovery. Today, Rob will share details on oral cancer rates and risk factors, the role of HPV in oral cancer, proper patient communication and oral screening protocols, and how to use adjunctive screening technology. Before we get started, as always, just a few housekeeping items. While attendees are in listen-only mode, you're invited and encouraged at any time to submit your questions or comments using the question button on your screen. Following the presentation, I will share your questions with Rob, who will be happy to answer them. Attendance at this presentation entitles you to receive 1.5 hours of PACE-approved continuing education credit. Shortly following the webcast, you will be emailed a brief survey with instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And with that, it is now a distinct pleasure, and I'm very excited to have this opportunity to introduce to the Practice Perfection stage for the first time, Robert Whitman. Greetings, Robert.
Well, thank you. Thanks for having me.
My pleasure.
All right. Well, I'll get started here, and thanks everybody for attending. I know taking some time away from family and it's never the easiest thing. So hopefully we'll have a good course here, and we'll go over some good content. So hopefully the title got everybody probably intrigued and interested, since we do talk about sex, drugs, and oral cancer, and I assure you that all three of those topics will be spoken about, and unfortunately the first two have been leading to the third thing. So I'll kind of get started briefly. My background's been in engineering my whole life. So I've been in biomedical engineering. I grew up in New Orleans. I moved to Houston after I graduated with a master's of biomedical engineering, and I started working at the top cancer center in the nation as far as cancer progression goes, and it's MD Anderson Cancer Center. A few disclaimers for me that I always like to share when we get started. I was born in New Orleans, so we were raised to consume alcohol at a fairly young age, if you will. I am an engineer, so I do like to talk in trends and graphs and numbers. So when you guys see a lot of these charts and facts and figures, I have a lot of resources that we'll share, but I try to concise the message down as quickly and briefly as we can. And then I am the founder and CEO of Forward Science. We do have products on the market, and we'll share some of them, but my main objective today is really to cover oral cancer, where we are, the rates, the trends, and really what we can do as a dental community to start changing some of these trends. So start with this, is what month is Oral Cancer Awareness Month? And right now we're not far from it, or a few days away from it actually. So Oral Cancer Awareness Month is the month of April. Most people in the dental industry don't know that because there's not many oral cancer awareness communities that share enough about it. We all know what month Breast Cancer Awareness Month is. We all know everything of that nature, but when we speak about oral cancer, there really isn't a lot of initiative for people to educate the dental offices, but even more so patients. So that's really our goal, is to help empower you all so that you can help educate your patients on this important topic. And really start to kind of begin with a challenge. A lot of times we've been educated through whatever facets of education, whether it's a dental office or you're in CE courses like this, which I'm happy to be a part of, and it's a great opportunity to continue to educate. Dental school, hygiene school, a lot of times we're given part of the picture, and there's a lot more to what we need to look at and a lot more education we need. So we always challenge everybody to change the way they look at things. And when you look at the world of oral cancer, which again we'll go over here quite extensively, but a lot of people were trained to look for red lesions or white lesions or lumps or bumps, which is all still the standard of care, but there's a lot more information that we can start to begin to collect with advanced technology. And that's really what we want to focus on here, is changing the way you look at every patient. Demographics have changed, rates have changed, and now it's really our initiative to begin to look at this disease in much different facets. So I'll start with talking about cancer in general. If you look at cancer as a whole, not just oral cancer, we're seeing cancer affect 1 out of every 2 men and 1 out of every 3 women. So if you look at the average American family, there's 5 people, and even more so if you want to talk about changing the rates and trends, but also looking at how to impact offices emotionally. This is actually my family on the screen. So engineers do a very good job of talking in stick figures and numbers, but when you take those numbers that we see on the screen and now relate it to my family, I grew up with 2 older sisters, my mother, my father, and I. So one of us, myself or my pops, or one of my 2 sisters or my mom, 2 of us 5 will be diagnosed with some form of cancer in our lifetime. And again, these are things that when we started getting in the cancer industry and the oncology industry, we didn't believe it. We have some of the most advanced healthcare systems in the world here in the United States, and these numbers have been proven true for many years in a row. Worldwide, cancer is actually the #1 cause of death. It's overtaken cardiovascular disease and heart disease to be the #1 cause of death. But here in the United States, that's not the case yet. Cardiovascular disease #1, heart disease is #2. But by 2030, we are projecting cancer to be the #1 cause of death. So we're looking at an increase by 45% in the number of cases. That's going to take here in the United States 1.6 million cases to over 2 million cases of cancer. So again, when you're looking at trends and rates and numbers, this is not going in our direction. If you now look at how big the oncology market is and how many patients are actually undergoing cancer treatment, it's grown drastically in the past 3 or 4 decades. So the good news is, if you look at 5-year survival rates, we are seeing a lot of survival rates increase for almost all cancers. So one of my pet peeves with the cancer world is, if you're looking at survival rate, it's looked at as a 5-year survival rate. My concern is that if I'm diagnosed with cancer today, I want to live way longer than 5 years. So 5-year survival rate is what they metric everything by, and it's mainly because they can't follow patients for a long period of time. There is a 15-year survival rate that people metric lives by, but it's hard to follow those patients for those 15 years. I mean, it's hard enough to get patients to come to a dental office twice a year, much less follow them for 15 years. So if you look at all rates and trends as far as cancer, we look at 5-year survival rates. So that's kind of one thing to know when you're looking at these statistics. But if you look at all the numbers on the screen, and if you look at all the cancers, we are seeing a lot benefit as far as early discovery. We're seeing public awareness a lot better off. So everybody knows, or at least all females know, to go get your annual mammogram, to get your annual pap smear. Males know to get your annual PSA test. So because of increased public awareness, we're seeing a lot more early discovery because of technologies getting better, because Pap smears have been created in 1950, because the PSA test has changed the game in prostate cancer. We're seeing a much better rate for survival for these patients. And that's synonymous with on the screen. The problem is there's one cancer that we're not seeing that's 5-year survival rate increase, and that's oral cancer. So in the past 3 decades, we have not seen an increase in survival rate from oral cancer. Right now, the survival rate is still around the same number. A lot of the different reports come out. Typically, if you look at studies, they come out every 10 years. So depending on what statistics you're looking at, they may come out. So the latest stats you see here on the screen are 2007, and the numbers are still the same according to today's studies that are coming out. So we're seeing about a 60% survival rate depending on what stage it's found, but typically with oral cancer, we're finding when it's pretty late, and that's really the number one concern. So if you look at 5-year survival rate, again, the good news is most cancers, we're seeing an increase in survival rate. The bad news is we're not seeing that increase in oral cancer. So that's one concern. The second concern is we want to look at the incidence rate. So when we talk about incidence rate, incidence is the amount of patients that are diagnosed with cancer. And that number has grown every single year, 8 years in a row from the oral cancer world. And that's a big concern for us. So in 2011, we've seen about 25,000 cases. And now we're seeing this year, we're projected, and these numbers came out about 2 or 3 months ago, we're projecting over 51,000 cases of oral cancer here in the United States of America. So we're not talking about an increase in a few hundred patients or even a few thousand patients. This number's doubled since 2011, and that's one of the biggest concerns, of course. So if you look at incidence rates, we're seeing more and more patients diagnosed. If you look at survival rates, we're not really having any advanced technology infiltrate the market so we can find lesions earlier. And that's really left us at the statistics that we've probably all heard quite a few times because it hasn't changed in a long time, that 1 American dies every hour from oral cancer. So if you think of that in not just 1 American dies every hour, but every hygiene patient that you see in every office, every time you're at the office, every hour we see 1 American die from oral cancer, and that number is starting to get worse and worse. So again, we're starting to have this big culmination of where we are today with oral cancer. 2 things I want to focus on this slide is, for one, have you been screened? So many times, my wife is an ER nurse, so I can kind of talk about this firsthand. So many times clinicians incorporate the latest technology or the latest procedures or whatever it may be into their medical practice, and you don't do it on yourselves or your staff. So what I'll say is make sure that you screen each other. You know, whether you have advanced technology or not, whatever that may be, make sure that whatever the standard of care is you're doing for your patients, you're doing for each other in the office. Because as we'll go over some of the rates here in a minute of who's getting oral cancer, it doesn't discriminate right now. It's really affecting an array of different demographics and patients. The second thing is, who do you screen? So when you start looking at numbers of who do you screen, these are where we start transitioning over to the new demographics that we're seeing, the new rates, the new trends. So what the ADA has trained people for, probably the bulk of the time, everybody here is listening, has learned about is traditional risk factors for oral cancer. You know, the ADA says you're going to screen these patients that are 40 years of age and older, because we know age is going to play a role into cancer history. We know anybody with a previous history of any type of cancer typically has a higher increased risk for another type of cancer, which is pretty standard. Tobacco and alcohol use play a big role into your risk factors for oral cancer. So again, everybody knows these patients are still at much higher risk than the patients that don't have these risk factors. But right now, through many different studies, there's a lot of different information out there that is telling us that up to 60% of these patients that are diagnosed with oral cancer occur in patients that don't smoke, don't drink, don't chew tobacco, and they don't have any significant lifestyle risks. And they're under the age of 40. So if you're in your office, you're just screening this population that's up here on the top left, then unfortunately, we're missing half these cancers. And the studies show it's either 50 to 70%, depending on which study we look at. And that's really from sexually transmitted HPV. So although it is something that's newer to talk about, it is something that we're learning a lot more about. There's a lot more evidence to prove now that we are seeing sexually transmitted HPV occur in patients that are younger. We're seeing it typically happen in patients under 40 years of age, and we're seeing it as a 5-fold increase under that age group. So, now when you're having discussions with your patients, this is something that we have to bring up. The ADA still talks about 40 years of age and older, but the Center for Disease Control, the CDC, actually mandates 17 years of age and older for annual oral cancer screening, and that's what they recommend. So if you look at those numbers, that's where we're seeing younger patients being diagnosed with oral cancer from HPV. And I'll go over a few more stats here in a minute about that. But whether people believe in the vaccine of Gardasil or not, that's always a topic that people want to go with. But I cover the Gardasil topic just because these very large drug companies do something very well, and they do market analysis. And what they've done is they've proven that younger patients are having sexual activity at a much younger age. And that's why Gardasil is actually approved for 9-year-old boys and girls. It's because the way these vaccines work is we're trying to vaccinate the patient before they become sexually active and before they become HPV positive. So that's why a lot of these vaccines are recommended for younger age groups. But again, whether you believe in the vaccine or not, that's not the message. The message is we know that patients are having sexual activity at a younger age group. And unfortunately, through education in high schools, grammar schools, middle schools, they're being taught that oral sex means safe sex, means you can't get pregnant. And that's unfortunately not the case. So we have some clinicians that we work with that are going to high schools and middle schools and educating them that oral sex can still cause cancer. And that's really where we're finding ourselves today with a lot of different types of HPV found in the mouth. The past 3 decades, we've seen an HPV positive increase for oral cancer. So HPV positive oral cancer has increased about 225% in the past 3 decades. That's a big concern. 225% increase for anything is a big concern, and even more so, seeing that increase very drastically just in the past 2 decades is the issue. The good news is we are seeing an HPV negative oral cancer decrease. So hopefully we're educating patients enough to stop smoking, chewing tobacco, all the carcinogens that we're unfortunately putting in our mouths for a long time. We do have a lot better education for these patients that are using tobacco and alcohol. But unfortunately, the decrease in tobacco and alcohol related oral cancer is really masked by the increase for the HPV positive oral cancer that we're seeing. And this is a statistic that came out quite a few years ago. Unfortunately, the numbers are continuing to rise. We don't have really that long-term study and that data to tell us how big the increase is, but we're seeing HPV positive oral cancer increase pretty drastically. So again, these are the numbers, these are the facts, these are the figures that we're concerned about. But the thing that we always try to stress is patients are going to want to talk about HPV. HPV is something that is very, very common, that 3 out of every 4 people are infected at some time in their lifetime, and their body fights it off naturally. So there's over 120 different strands of HPV. Everybody thinks that HPV is going to cause everybody's cancer, and that's not the case. So 75% of the people that are infected with HPV, our body fights it off naturally, and we don't even know we've been infected. So that's how common it is, and that's how our body fights it off. But the problem is there are 3 or 4 different strands that have been proven to cause cancer. And that, of course, those are the strands that we're seeing manifest in the oral cancer world. HPV 16 and 18 cause the vast majority of cervical cancer. Probably about 99% of cervical cancer is caused by those 2 HPVs. And they cause so much HPV cervical cancer that they're actually trying to see if it's worth doing just an HPV test for cervical cancer. So there's a lot of science behind what's going on with cervical cancer, but without having to draw stick figures, how does HPV get from the cervix to the mouth? You guys can probably figure that out. We have a pretty educated crowd here. That's really where we're finding HPV found in the mouth. Typically, it's HPV 16 that is causing 90% of these HPV positive oral cancers. And that's really the concern. So if you look at, this is a brochure that we have, and if you look at the bottom of our brochure, we're going to educate patients on HPV exposure to oral cancer. So kind of going through the list, We know one of the hardest things to do is educate your patients on how important it is to do an oral cancer screening, which includes, looking for risk factors like HPV. This is something that we try to help you educate your patients on. So one of the bottom statistics there is important. We're seeing typically HPV happen 2 times more in males than females in the mouth, obviously because males don't have a cervix and we're not getting HPV in the cervical world. So there's some numbers. If you're looking to HPV-related cancers are 6 to 7 more times more common in men than women. And then we also have the statistics at the bottom that 6 or more oral sexual partners gives you 8.6 times more likely to have oral cancer than those that have never had oral sex. Again, these are all facts that have come and the sources are there. This is information that we try to share with you all so that you can educate your patients on how important it really is to get screened. So looking at the numbers, we're seeing over 50,000 cases every year. We're seeing almost 10,000 diagnosed, 10,000 deaths every year from oral cancer. And HPV is really the big issue that we're focused with today. So if you look at all the numbers, again, these are different topics. Our big focus is really helping you all educate your patients because patients are not hearing this information. They're hearing a lot of different things through social media. They're hearing stories like Michael Douglas's story. Michael Douglas told the world that sex gave him cancer. Nobody was really sure what that meant for a long time. And then he told the world that oral sex gave him oral cancer. And Michael Douglas was diagnosed with a late stage HPV positive oral cancer. And thankfully, if there is one good thing about HPV positive oral cancer, it is that the body fights it off pretty naturally when chemo and radiation start to counteract it. So everybody thinks that Michael Douglas has all the money in the world and he's going to save his face and be able to fight better than we all. But I assure you that if any of us are diagnosed with the C word, we're going to do everything we can to fight it for ourselves or our loved ones. So it's not that
I think he may have genes going for him too, Rob. His dad is still alive. I think he's 101.
Yeah, and wow, I didn't know that.
Yep.
And that, that helps. Genetic disposition always helps out. And at the same time, it also hurts when 7% of all cancer is genetic. So it's one of those things that for him, he told the world his story for quite some time, but after a while, the hard thing about oral cancer is there's a lot of different risk factors, but unfortunately, a lot of these risk factors are self-induced. So we just talked about tobacco and alcohol. We talked about smoking and smokeless tobacco. We talked about HPV. All those risk factors are really self-induced from ourselves. So anybody that's diagnosed with oral cancer doesn't like to talk about it because they feel like they did it to themselves. And that's really why we are where we are today with oral cancer. We don't have that spokesperson that we always want. We don't have those patients that can go out and tell their story because unfortunately they don't live long enough to tell their story, or if they do, they've been through chronic head and neck radiation, and it's very troubling when you've gone through that much radiation. So, again, for us, we want you all to understand the risk factors, the trends, where we are today. At the end of the day, there are patients out there that, our goal is to do 2 things. It's to find lesions early so we can have a much better survival rate long term. It's also to find lesions early so that these patients don't have to go through these drastic surgeries and have a different way of life. So this is a good patient, a good friend of ours from being in the oral cancer world. And Eric was diagnosed at the age of 39 years old with metastatic oral cancer. And it was just one of those rare cases. And he was given a very small, in the teens % to live. I'm happy to say he celebrates his birthdays now, not in years he's been alive, but years he's been cancer-free, which if you start to think about is pretty grounding. He's now 7 years old this year. And by 7 years, I mean 7 years cancer-free. But with him, I had the opportunity to spend some time with him. Thankfully, he did live past that 5-year mark. And if you live past 5 years for 5-year survival, you do have a much better long-term survival rate. But for these patients with oral cancer, we're trying to save their lives by screening earlier and find lesions earlier. But even more so, if we're able to extend that quality of life, that's really another goal that we're trying to have. So for him, if you look at his picture from his left leg, he was a cross-country athlete and he loved running. I played college baseball, so I don't believe running is a great option. I just run from one base to one base, but he ran and loved running. So if you look at his left leg, they took out half of his leg to reconstruct his jaw after they had oral cancer surgery. So that's a pretty radical thought process, that he now can't walk longer than a mile at a time without sitting down and resting. And even more so during his surgery, I asked him, what's the most concerning thing that you have to live with? And it's not people looking at you, he said, because if you can beat cancer, then you don't care what people think. The biggest thing that he's worried about, and the biggest concern, is that every night when he goes to bed, he kisses his wife and his two boys goodnight, and he doesn't feel a thing. So from all of his radical surgeries and the drastic surgeries he had, he now doesn't have any sensation on his lips. That's the thing, those are the side effects that we're trying to prevent. So yes, while our goal is to help patients live longer, our goal is also for the fact that if we can catch it early, maybe it's just removing part of the tongue, and by no means is that easy, but part of the tongue as opposed to removing half their jaw and reconstructing with their leg. So again, that's the goals from what we want to do today. That's our outcome. One thing that I always want to share with people, because in a lot of different literature and numbers and statistics, people one of the first books that we were asked to read, or kind of forced to read in engineering school, is How to Lie with Statistics. So when we talk about oral cancer, I want to be clear that oral cancer is really comprised of two different types of cancer. It's oropharyngeal cancer and oral cavity cancer. So oropharyngeal, which for me, being a non-clinician, is throat cancer, and oral cavity cancer, of course, being kind of the front of the mouth types cancer, that's all talked about under oral cancer. So the cancer world just metrics it under one cancer. It's called oral cancer, but it is included in both the oropharyngeal and the oral cavity. Oropharyngeal cancer is where we're finding the vast majority of HPV positive oral cancers. So the majority of HPV positive oral cancers are found in the back of the throat. Now, oral cavity cancer is predominantly from these other risk factors like tobacco and alcohol use. So when a patient's diagnosed with HPV positive oral cancer, typically it's in the back of the throat. A lot of these patients, you can't visibly see it. So we're able to palpate it around the neck. And that's really where a lot of clinicians, and we'll go over that in a minute, stress the visual palpation, because you'll be able to feel a lymph node in the neck inflamed or something going on down there. That's really where we're finding a lot of these HPV positive oral cancers. So again, oral cancer is comprised of two different cancers, and they almost have two different kind of treatment plans. If you go over to MD Anderson Cancer Center and you have HPV positive oral cancer, you're going to be treated completely differently than if you have HPV negative oral cancer. And the good thing is HPV positive oral cancer, again, is very easy to treat. As long as we catch it north of the neck, we can go in there and do some pretty good radiation and chemotherapy. We can keep these patients away from cancer metastasizing long term, and a lot less side effects because it's not in the bone per se. But oral cavity type cancer, when it's tobacco and alcohol related, unfortunately, that's when we have to do some pretty radical surgeries. So again, that's kind of a background of where we are today with oral cancer, the changing trends, HPV positive, HPV negative. At the end of the day, we're always looking for early discovery. And if there's a reason to get screened, it's really so that we can find lesions earlier and have a much better long-term survival. Just like most cancers, the government and insurance companies are spending a lot of money on treating these patients. The problem is, or one of the concerns with head and neck cancer patients is it's a lot more than just a simple surgery. And there's a lot of complications that go on. You all are clinicians in the dental space and deal with oral health care in general. These patients have a lot more complications. You can't just remove their tooth or remove their jaw and reconstruct it. There are a lot of complications which lead to suicide rates, and it is a very deforming disease. So we are seeing suicide rates increase drastically for head and neck cancer patients. And we're not seeing a lot of these patients live long-term as far as 5, 10, 15-year survival rates. So those are the things we try to focus on. If you look at survival rates from which stage it's diagnosed, this is a graph that you'll pretty much see for all cancers. If you look at stage 1, stage 2 cancer for oral cancer or any cancer, you're going to have a pretty higher, a lot higher survival rate, 80, 90%. As cancer metastasizes, as it grows throughout the mouth, or it grows throughout the body, as it goes from stage 1 to stage 2 to stage 3 to stage 4, of course, we have a lot less survival rate chances because our body's going to be attacked from across the board. So This is not far off from most 5-year survival rates. The good news is with most survival rates with cancer, it's kind of we shared earlier, the reason that we are seeing an increase in survival rate is because we're catching breast cancer at stage 1 or stage 2. It's because pap smears are catching cervical cancer at stage 1 or stage 2, or even pre-cancer. It's because prostate cancer is getting caught by a PSA test at stage 0 or stage 1 or stage 2. So that's why we're seeing an increase in survival rates, because there's advanced technologies in other markets. Patients are being more educated to get screened. So we're going in to get screened annually for different types of cancers. Unfortunately, in the oral cancer world, we're not seeing that increase in survival rates. And that's mainly because of early discovery. Typically, when we find oral cancer right now, we're finding 70% of all these oral cancers when they're in stage 3 or stage 4. And that means we have less than a 50% chance to live. So if you look at your patients that we're finding, 70 out of every 100 oral cancer patients have less than a 50% chance to live. And that's the big concern. So why are we finding it late? Typically, when their eyes are able to see oral cancer, studies show that it's usually a secondary tumor that we find. So by the time you see a red lesion, you see a white lesion, you feel a lump or a bump, studies show that that's actually a secondary tumor. The primary tumor started somewhere else. It originated somewhere else. We just didn't find it. That's really the main concern. It's how do we find these primary tumors, these original tumors, so that it is just stage 1 and we can just go and remove that lesion and have an 80 to 90% survival rate. So again, that's the goal. Early discovery is the goal for everything. If we look at oral cancer specifically, we know that if we're able to catch it early, we're going to have that 80 to 90% survival rate. And there's a lot of potentially malignant lesions, precancerous lesions, that are found in the mouth that may never become cancer, but they may become cancer. And if we're able to find it when it's still potentially malignant, being stage 0, then we're going to have a 90% or above survival rate. And that's really our goal. So how do you do that? Again, just kind of transition over the facts and figures. All these facts and figures are startling. It's one thing to have the knowledge of where we are today with the cancer world, specifically oral cancer. But if you look at where we are today as far as technology, that's really where we need to take that proactive approach. If you look at a lot of other cancers that we see, a lot of other specialists in general, medical field, dermatology, they cut 5 moles out for every patient every year. ENTs, they're typically going to go in any lesion they see abnormal, they're going to cut out. Unfortunately, we're not seeing a ton of proactive approach for oral wellness in general. A lot of times when patients come in, they have a pain and we try to treat the pain, which of course is understandable. But if we're able to change the way we look at these patients, find these lesions earlier, then we have a much better survival rate long term. And that's really what we're trying to do. So by doing that, incorporating a simple protocol. So our recommended protocol that we've worked with a lot of specialists is a simple FACT oral health protocol. We want to screen early and often for our patients. So 17 years of age and annually, we want to implement oral cancer screening. You can always screen younger patients. You can look for, just like you're looking for other risk factors for these younger patients. Unfortunately, we've seen HPV in patients as young as 5-year-olds, 9-year-olds, 12-year-olds. It's not always that young. Typically, HPV is sexually transmitted, but at time it can be mother to child at birth. It could be sharing a drink after somebody. So it could be at a younger age, but we are seeing it typically from the 18 to 30-year-olds that we're seeing with HPV. We also want to use advanced technology. Again, just like every other market that we always try to study, there's medical professionals that use advanced technology to find lesions earlier, and that's really what our goal is. So looking at what the protocol is, we always want to do a fluorescence assessment, and I'll go over kind of what that looks like here in a minute as far as technology. Cytology testing is something that's very advantageous in a dental and medical setting, but again, we'll go over this as well. It's not replacing a biopsy. So fluorescence assessment, cytology testing, the FACT protocol is really what we recommend, and it's something that we've seen a lot of success with in helping change these trends in some of our offices we were working with. This is kind of a graph that we have. The first step for every oral cancer screening is always going to be a conventional oral exam. It is the standard of care. It'll never be replaced. You have to go in, you have to pull the tongue out, look at the back of the throat, lumps and bumps. You have to do all that. So make sure you go quadrant by quadrant. If you see a lesion with the white light, then you're probably going to see it with one of these fluorescence devices. So that's always going to be the next step. But if you don't find a lesion, we still want to go ahead and do the fluorescence assessment. A lot of times, one of the misconceptions are with this technology that people, if you don't see a lesion, then you don't take one of these devices out. And that's not the case. And I'll go over some cases here in a minute, but fluorescence is going to give you the ability to see lesions earlier. It doesn't mean it's cancer. At that point, just like any other perio protocol that you have, when you see a red lesion or a white lesion right now, what is the protocol? The protocol is to have the patient back in 2 weeks. So just like your perio protocol now, if you're screening with a fluorescence device, it's the same protocol. If you see a lesion that's dark, again, I'll go over some images here in a minute, you want to have that patient back in 2 weeks to reassess that lesion. If that lesion's gone, everybody's happy. Patients are never going to complain if they come back in 2 weeks and you tell them that they're fine. I assure you of that. But if the lesion's still there, then we want to take the next step. The next step for every office is always varied. Some offices go straight to a biopsy. Some offices refer straight out. We've had a lot of benefit to cytology testing, and I'll go over some of that and how that works here in a minute as well. So again, that's the simple protocol. It's not hard to incorporate. We always want to make sure that you get trained, and we have ample training and support, but making sure that you understand where screening fits is important. So I'll go over how fluorescence works. It's been around for a long time. So people that want to talk about fluorescence and how new it is, I assure you it's been around for quite some time. At MD Anderson Cancer Center, when we worked there, we were using it for cervical cancer screening. So it's been used for cervical cancer, lungs. It's been used in the skin cancer world for quite some time. One of the longest uses of fluorescence technology is the GI tract, and Olympus has what they call a green light, and it's called green light technology. They shine a green light when they do an upper or lower endoscope, and what it does, it's looking for clusters of cells. So that's technology that's been used for a long time. They're just smarter than everybody else is, and they don't call it fluorescence because it's very hard to say and even harder to spell. But for Olympus, they use what they call green light technology. So I share that just to let you know that this isn't new technology. This is technology that's been around for a very long time. The #1 cancer center in the nation uses this technology in collaboration with British Columbia Cancer Center in Vancouver. They created this technology for many different types of cancer, cervical cancer, lung, and then the oral cancer world is the latest one that this technology has been launched in. So again, it's been used for a long time. Anytime anybody goes through MD Anderson Cancer Center in one of their divisions that they work with, in the ENT division, they use it, and then they also use it in the dental division for different types of screenings that they're doing. So the way it works, it's pretty straightforward, but it tends to involve a little bit more science. Typically, our cells have some fluorophores that naturally fluoresce. So whether it's NADH, FAD, there's collagen cross-links, there's elastin fibers that we're seeing. Our cells have some optical biomarkers that fluoresce naturally. So you shine a bright blue light on the tissue, and it's going to fluoresce a nice, healthy green color back. Now, nobody thought they'd see this again as Krebs cycle occurs. As we're using NADH and FAD as energy for angiogenesis to kind of grow this cancer, it's not hard to comprehend. If you have NADH and FAD that fluoresces healthy tissue back, and now you're using that NADH and FAD to grow and to kind of extend that cancer for angiogenesis, now you have less of that ratio, and now it means you're going to have less fluorescence. So any increased metabolic activity is going to have that less fluorescence because of this process. So again, not cancer only, any type of increased metabolic activity. One of the other things that we always look for is collagen cross-links. This is probably what you're going to see the most of when you're doing initial screening. Collagen, so typically our mouth has, our cells have nice healthy collagen tissue. As collagen is broken down, we're going to have a breakdown of collagen. It's going to cause it to have a lack of fluorescence. So there's really a few different ways that collagen begins to break down. There's thermal damage, mechanical damage, and chemical changes. Thermal and mechanical, burns and bites. So how do I decipher between burns and bites versus cancer? That's the 2-week follow-up protocol that we have to make sure we implement. So if you're using this technology in fluorescence and you see a lesion that's dark, it's not, hey, Rob, I just did an oral cancer screening and you have a dark lesion, so I think you need to come back in 2 weeks. It's really changing that verbiage and educating the patient on, look, we're using an early screening device, and it's going to give us a complete oral health assessment. which means it may be something traumatic. It may be a burn or a bite, or it may be something that's related to a cancerous lesion. We're really not sure. It is a screening device, but if you come back in 2 weeks, we're able to reassess that lesion and be on our way. And that verbiage really changes. Again, so from marketing oral cancer screening to now telling the patient this is a complete oral health assessment device, that's really where we want to focus when you're talking to patients, because it's not finding just cancer, and it's not a diagnostic device. So we're going to look for lesions. We're going to shine a bright blue light on the tissue. So if you're using Oral ID or Velscope, it's a bright blue light on the tissue, and the Identify device shines a violet light, which just fluoresces a little different color back. But you're going to shine a bright light on the tissue. Healthy tissue is going to fluoresce a bright color back, and that's pretty much how it works. Anything abnormal appears dark. So again, I want to stress this. Not anything cancer only appears dark. This is not a detection device. This is a discovery tool. These devices give you the ability to see lesions earlier, but they're not diagnosing what the lesion is. The best example.
Yeah, and that's why you go through this this protocol. Somebody could have burned their tongue on pizza the night before and might get something like this. Just means the tissue isn't healthy, but it doesn't mean it's cancerous.
Right. So, and that's what we try to hammer that home, because there's other studies and articles out there that talk about the false positive rate of these devices, and there isn't one. There's no false positive rate of your loops. Your loops don't detect a tooth fracture. Your brain does, and you do, but your loops help you see tooth fractures better. So I wanted to stress that, and I'll probably stress that 5 more times, so I apologize for belaboring the point, but this is a screening tool that gives you the ability to see lesions earlier. Now I'll kind of go through some lesions that we've seen already clinically that we're able to kind of go ahead and understand more. So healthy tissue, a bright green yellow color, abnormal tissue appears dark. Then we go from there. And what the technology is really doing is it's shining past the epithelial tissue, and it's really looking at what's going on in the basement membrane. So this is a cross-section of your epithelial tissue, and obviously this is not to scale, because the cross-section of the epithelial tissue is about the thickness of a human hair. So it's pretty thin, which is why you can draw blood pretty easily. But if you look at where cancer starts, typically we're seeing cancer when you visibly see a lesion when it's stage 1, stage 2, stage 3, and that's when the lesion becomes visible. Whereas right now with this technology, we're trying to find it when it's still dysplasia, when it's still moderate dysplasia, mild dysplasia. So we want to catch that lesion much earlier, and of course we have a much better survival rate at that point. So this is a good slide that kind of gives you that image to be able to see. So I'll go through some images. Again, conventional oral exam, first step, white light, palpations, lumps and bumps, always the first step of every protocol. And then go ahead with your Oral ID device, screen your patient, and do that. So we stop talking in oral cancer exams and really start in complete oral health assessment or enhanced oral health assessment. And whatever the verbiage that you like to share is, we're using this technology to go ahead and look for anything that's early stage lesions, from HPV to cancer to precancer to any other types of lesions that we're able to find. Conventional oral exam, palpations, lumps or bumps. You want to make sure that you pull the tongue out. Again, the oral pharynx is where we're finding a lot of these HPV positive oral cancers, so make sure we do the palpations on the neck. And then we go ahead with our Oral ID exam. Technologies are pretty straightforward. You shine a bright blue light on the tissue. You wear a pair of glasses that block out all that blue light, because we only want to see the fluorescence coming back from the device. So we supply a pair of glasses, 2 pair of glasses, 1 for each clinician, so we can really go ahead and do a comprehensive exam with 2 eyes for both clinicians. And the way it works, again, is we have a ton of images. These are high resolution images that you're seeing probably on a beautiful computer screen. So everybody's going to say, I don't need a device to see that lesion. But I assure you, zoomed out, no ring flash, no HD, beautiful camera. This is a lesion that may not be as prevalent, may not be easy to see, and now we see a much distinct, lot darker lesion. So again, the conversation with the patient isn't, hey, Rob, I see a dark lesion, I think it's cancer. Come back in 2 weeks, because that's not what we're trying to portray. It's, hey, Rob, we found a lesion on your tongue, and we're not really sure what it is. You may have burned your mouth, or it may be something more severe. If we can have you back in 2 weeks to reassess that lesion, we'll learn a lot more in 2 weeks. And that's it. Have the patient back in 2 weeks, reassess that lesion. This lesion was still there 2 weeks later. They did a biopsy, and it was minimally invasive squamous cell carcinoma with HPV positive for 16. So, again, this is a lesion that we're seeing a lot more of. It's typically not found on the tongue, but right now there's a lot of new information out there with different lesions that we're finding all throughout the mouth. This was a lesion that we were able to treat the patient for a lot earlier, as opposed to kind of a big case that we have to do if we don't find it later on. And again, a lot of times patients come in complaining of pain. The hard thing is with cancer, typically pain isn't associated with cancer until its later stages. So if a patient's complaining of a lesion that's painful, it's either advanced cancer or if it's just an aphthous ulcer or something of that nature. A lesion like this really will not typically present itself with any type of pain. Back of the throat, oropharynx, this is a lesion that we're able to see. Again, these are lesions that we're starting to see a lot more prevalent, a lot more pronounced now. And this turned out to be dysplastic tissue. So again, precancerous lesion may never become cancer, but unfortunately, we don't know which dysplasia lesions become cancer and which don't. So we're still going to have to go ahead and treat this patient. They went and did an excisional with this. They actually ablated it with some laser, and we're able to go ahead and take that lesion out for that patient. Palate area, lesion initially didn't really present itself much, a lot more pronounced, a lot darker. Had the patient back in 2 weeks, turned out to be moderate dysplasia. So again, not to belabor the point, there's a lot of lesions that you're going to see. Not all of them are cancer. So this is a perfect example of a lesion that, we're not looking for just cancer. We're looking for anything that's abnormal. And this lesion turned out to be an aggressive amyloblastoma. So when you look up what an amyloblastoma is, it's actually a benign tumor that continues to grow until you resect all the way down to the bone. So this patient technically didn't have cancer. So if anybody's worried about, what if you screen a patient with cancer and what if it's something else? This is the something else that you're trying to find as well. This is the aggressive amyloblastoma that would take this patient's jaw, and it did take this patient's jaw. We had to cut out quite a bit of this.
And is the reason they don't call that cancer, Rob, is because it doesn't metastasize?
Yeah, technically it's benign. So by definition, it's a non-carcinogen. So when people always say, I looked for cancer and I found something else, by definition, that's a false positive. So if somebody says, hey,
still do a lot of damage.
This patient this is a 49-year-old retired nurse that obviously was going through ortho treatment here. So, look, there's a lot of lesions that we really don't understand right now, but we know it's still affecting patients, and this technology is helping us see these lesions earlier. Here's a back of the throat oropharyngeal lesion. You can see on the left side, it's got some leukoplakic tissue around it, but now it's a lot more pronounced. It's a lot easier to see. Again, trying to find these lesions earlier, making sure that we understand what's going on with these patients. Lesions like this is where this technology is used in the specialty market. So for periodontists, oral surgeons, ENTs, they use this technology not for initial screenings. They use it to see how large the biopsy margins actually are. So this technology is really twofold for initial screenings, but also fluorescence has been used for a long time for surgical margin delineation. And that's really something that's beneficial for this technology for the ENT kind of oral surgery type market. And this turned out to be mild moderate dysplasia with bacteria. And then they did a biopsy and confirmed that it was cancer right where the lesion was, but they were trying to get the margins a lot cleaner. So again, kind of back of the throat, oropharynx, a lot more lesions that we're starting to see in the oropharyngeal lesion aren't all HPV. We're starting to see acid reflux and GERD pull up, and this is a GERD lesion at the back of the throat that we were able to see. It may not cause cancer today, but 3 to 5 years from now, if we don't change this patient's diet and change the way they sleep, they're unfortunately going to cause their own cancer. And that's really some things that we're starting to see a lot more nowadays. So an HPV lesion that we found at one of our clinical studies as well. So you can kind of see how the technology works. Again, it's not a diagnostic device. These are discovery devices. It's giving us the ability to find lesions. We want to then document those lesions, collect as much information as we can, and then have that patient back for that 2-week follow-up protocol. We do have some cool features that you can take images with. So we have a smart filter that you put on a smart device, cell phone of any type, whatever that may be. Now you're able to take the Oral ID device, put that filter on your cell phone, and take clinical images just as you see them live with your patients. So it's a great way to photo document. So when that patient comes back in 2 weeks, you know where and how big the margins were, the lesions were, or if you refer the patient out, you just email that picture over to your patient or to the specialist. There is no patient information in the images, so there's no HIPAA issue because you're not taking a picture of the patient's name. It gives you the good ability to go ahead and do that and to collect some good information. And then after that, what do you do? So again, we've kind of gone over fluorescence. It's very beneficial. We've seen a ton of offices incorporate it and find lesions earlier. Now what do you do? And that was one of the biggest concerns that we've learned was, I found a lesion, it's dark, had the patient back for 2 weeks. What do I do now? A lot of times people are referring out for a biopsy, and sometimes specialists aren't ready to do biopsies right away, or we get the feedback that it looks like this, it looks like lichen planus, it looks like a cheek bite. Unfortunately, the it looks like doesn't always mean that's what it is. So what we've been able to do is really incorporate a cytology test for those lesions that we're 85% sure it's lichen planus or a cheek bite. Now, if we think it's cancer, we're going to go do a biopsy right away, and everybody should always do that. If you see a red bloody abscess, we need to get this patient off immediately. But if it's a small minor change and it's something we're concerned about, we're not 100% sure that it's a cheek bite, it's still there in 2 weeks, that's where cytology has been beneficial for our patients and for our clinicians. So again, these are the different types of diagnostic tests that we have available. If you look at cytology testing, historically, cytology testing has been very beneficial for many different parts of the body. Again, same technology we've been using for other mucosal cells. Technically, cytology is exactly what's being done in the cervical cancer world. We call it a pap smear, even though it's not a pap smear. It's very similar to what was done in the past with other technologies on the dental market with the brush biopsy. So that's technology that we used in 1950 for cervical cancer. Now we've kind of graduated from this, collect some cells, smear it on a slide. What happens is with these cells, the slides tend to have 2 to 50 cells on top of each other. So it's very hard to diagnose what's going on with that lesion. Nowadays, we're able to do a liquid-based cytology, and it gives you the ability with a very non-invasive swab to collect those cells, put it into a vial, send it back to the laboratory, and the laboratory is able to then create the cell with a monolayer, meaning one cell on top of each other. There's no cells on top of each other. It's one cell layer, and now the diagnosis is sky high. So now instead of having the word atypia all the time, you're getting a full-fledged clinical diagnosis to find out what went on with your patient. And it's really been able to change the game in the way cervical cancer has been treating, because now they don't do pap smears anymore, even though it's kind of the brand name. What they do in the cervical cancer world is they do liquid-based cytology. So it's actually thin prep or clear prep. Now with the oral cancer world, we're able to use that same technology. So you're able to now take the 21st century liquid-based cytology to help diagnose what's going on with your patient. Again, if you think it's cancer, we're not going to do this. But if you think it's 95% sure it's an aphthous ulcer, lichen planus, this is really where we're able to be the intermediary test for these offices that aren't getting diagnosis and biopsies done as quick as we'd like, because it unfortunately either patients not going to the specialist or specialists aren't doing biopsies as much as we would like. So liquid-based cytology is something that you've seen. This is some of the results that we've seen. So typically, again, it's you acquire the cells very non-invasively, plunge it into the vial that we see here, send it back, and now you're able to diagnose very quickly within a week what's going on with this patient. And here's some of the pathology reports that we've been able to diagnose. Again, any type of atypia readings for us has been cancer. What we're not able to do with cytology is tell you how in-depth the cancer is, because we're not looking from a morphological standpoint. We're looking from a cellular standpoint. So we just see a bunch of cells next to each other. And atypia for us has been cancer every time. The oral pathologist that we work with that reads this then calls the office and pretty much says, hey, we need to do a biopsy because we need to confirm that it is cancer. But we've seen atypia quite a bit. We've also seen positive for herpes, candida organisms. We then are going to give you a treatment recommendation. The oral pathologist typically gives you a treatment recommendation so you can go in and actually understand what's going on. Typically, if there's anything positive for the cytology results, you're going to get the information and we're going to have somebody call you and have a discussion with what's going on. I was very surprised, and we've been surprised with the thousands of cytologies that we've gotten back. These are some of the results. So it's actually not just do a cytology, cancer, yes or no. We've been able to diagnose traumatic ulcers, reactive cells from inflammation, herpes, aphthous ulcers, candida albicans. Of the lesions that we've been able to cytology, we've seen about 7 to 8% of all the lesions come back positive for candida albicans, which is very similar to the cervical yeast infection that we're starting to see. So again, we're starting to see a lot of different information. What do we do with these lesions? that's really where we help you game plan. But being able to diagnose what's going on with your patients is really the highest priority. So that's really what this gives you the ability to do. And then there's other diagnostic tests like pH tests that are on the market. One of the things that everybody focuses in on dentistry is pH values and how it's helping or how it's eroding teeth, but nobody's really testing for pH. So we launched a pH test a while back to give you the ability to understand what's the pH levels of your patients. So if the patients are having some issues, we're able to kind of figure out what's going on. We do have an HPV test on the market as well. We can kind of go over a lot of that. There's other HPV tests on the market. So what we also want you to do is market your practice and differentiate what you're doing. We've had a lot of offices incorporate this technology, and I'll kind of go over marketing at a different time. That's not the goal behind this, but we've had offices incorporate how to market this technology because we want our offices to really get patients to say yes for screening, and then we want to go through the value behind what you're really providing for them. So whether it's YouTube videos or social media posts, posters in your waiting room, we've had the ability to really market your office differently as opposed to just having a device to screen when patients ask. Now we have social media posts that you post every month, or it's social signs that you hold up, and now patients are putting on Facebook that 50 Shades of Oral Cancer, which nobody really knows what it means, but it's great marketing. April, we're doing the Kiss Oral Cancer Goodbye campaign, where we're trying to get patients to pick their favorite color lips and tell their friends to come get screened at your office for oral cancer. So again, our goal behind Fun Marketing campaign is to bring the awareness to oral cancer so that you can have the educated conversation with your patients. And that's really been the focus. So changing the way offices market about oral cancer, screening patients that are younger, there are revenue opportunities behind it. We have quite a few offices that are incorporating oral cancer screening, and they're charging for it. Dental insurance codes are there, but as you all probably know, dental insurance codes aren't really the first ones to jump on board. So most of our offices present it as a copay, as a fee for service, whatever the verbiage may be, we help with that. And there's quite a few dollars that our offices have been making with just incorporating simple technology. We've been able to incorporate, depending on how many hygienists you have, we've had offices that make between $2,000 and $5,000 every month. Again, making sure that we're adding value to the patients. Patients are happy to pay $20 when they know they pay $20 for a pap smear mammogram when they understand the risk factors that are there. So these are the types of things that we're able to help you, educate you and your office to really add that value long term. Cytology also has codes as well that you can utilize for when you're doing cytology swabs. And then revenue opportunity for referrals. We have a lot of offices that are marketing this. They may be doing it for free, but they're marketing that send me your referrals, has your loved one seen the light? And now they're using this as a big referral opportunity. So it gives them the ability to go ahead and do that. So again, that's kind of what we've seen with cancer. I'll spend a few minutes here going over a little bit about the side effects that we've seen, and then I'll open it up to questions a little bit here. But transitioning from oral cancer now to really the oral health side effects that we've seen. We've been in the market, in the oncology market, for almost a decade or two now, and we've now learned a lot about the side effects that our patients are going through cancer treatment. And these are some of the visuals that we'll kind of give you. Depending on what type of cancer they're going through, most cancer treatments, doesn't always have to be head and neck cancer treatments, most cancer treatments are getting these three different types of complications and side effects: mucositis, xerostomia, and pH imbalance, which of course goes with really the first two. But mucositis is the number one concern that we're seeing now. And mucositis is something that we've seen prevalent in almost every single head and neck cancer patient, but even more so, we're seeing it in breast cancer patients, we're seeing it in bone marrow transplant patients. Most patients that are going through chemo radiation are going to get some sort of mucositis. And that's a big concern nowadays when you're talking about the oral health care of these patients. Mucositis is pretty rigorous, it's pretty challenging on these patients. From mucositis to not being able to eat or drink, that's really why the nourishment of these patients are important. If we can help with the mucositis, and we can help these patients really get through these treatments. And then xerostomia. We know dry mouth has been a big issue, whether it's a cancer patient, whether it's a patient that's on multiple medications. We've done a lot of research, and we've seen about 3 out of every 5 patients suffer from some range of dry mouth. And, again, whether it's tobacco use, alcohol use, prescription medications, open mouth sleepers. I mean, you name it. I feel like every patient today has some form of dry mouth or some range of dry mouth. We just have a hard time metricing how severe it is. But dry mouth is one of the big concerns that we see today. And again, prescription medications are causing a very big majority of that. And then there's complications behind it. You all know the complications of, in the important oral wellness world we live in, from all the things that we're seeing with heart disease, cardiovascular disease, gum disease, caries risk, all these things with important pH. So that's really why we always talk about the options that we have for dry mouth. There's not many prescription type options that are on the market for dry mouth, and that's really where we came out with a solution that's been beneficial. We've done a lot of research in cancer and oncology, and we were able to provide a new product classification that doesn't just mask the pain for dry mouth or mask the mucositis, the barrier, but we really want to go for the new treatment for mucositis and xerostomia. So Saliva Max has been something that we always try to share because there's really unlimited benefit for both xerostomia and mucositis for this product. So patients that are going through chemo and radiation treatment, we've seen a tremendous success. They simply rinse and spit with the product, so it's non-systemic. There's no drug interaction. They have the option to go ahead and use up to 10 a day, depending on the severity of their xerostomia. We've seen a lot of success for these patients that are going through oncology treatment, but also for patients that are on multiple medications, patients that are less severe xerostomia, but still xerostomia that's causing dry mouth and pH imbalance in their mouth. So again, what this technology is really doing is it's replenishing those ions. So Saliva Max is comprised of calcium phosphate bicarbonate ions that give us the ability to replenish those ions that are missing from a lack of saliva. We all know that saliva is comprised of calcium and phosphates and bicarb. So by definition, if you're able to replenish those ions, we're giving the cells a much better ionic balance, and we're able to really infiltrate those cells to replace those ions that we're missing. So by definition, this technology is really an artificial saliva that gives the patient a much better option to do a lot of different things with mucositis treatment and also from xerostomia treatment as well. So we've done a few different studies. Our latest study, this is the patient information from the latest study. We did a study on a regional head and neck cancer treatment, and the patients had tremendous results. But what we're able to also do is decrease the grade of mucositis by 1 level and delay the onset. And what that means for the patient standpoint is if you can decrease the grade of mucositis from a grade 3 to a grade 2, that's patients eating and drinking regular foods now as opposed to having to drink all their meals. So it's a drastic difference for these patients to decrease the mucositis. We're seeing a reduction in opioid use from the ability to kind of go ahead and treat that mucositis a lot quicker as well. So again, it's a simple prescription option. We're using it in a lot of different markets, but again, dental is the main focus for these types of products because we're able to see the benefit long-term for these patients. So whether it's—
I'm sorry, Rob, just a quick question.
Yes, sir.
How has use of this reduced the opioid dependence?
So there's a lot of patients that typically what we're seeing is there's studies with supersaturated calcium phosphate rinses being able to reduce the grade of mucositis, which means their pain level goes from maybe a 10 to a 7, but it also shortens the time they've had mucositis. So now if you have to take an opioid when you have mucositis, which is maybe a month, now you only have to take it for the time you have mucositis, which is only 3 weeks. So you're able to reduce the amount of opioids patients have to take. And we know the opioid epidemic that everybody's living in right now, and we can help with that, especially with an all-natural option. Then, of course, that's something that we've been excited to do as well.
Absolutely. That's great. Thank you.
So again, it's a prescription rinse. Typically, it's covered by the most insurances, and we can give you all the information later. But there is a copay assistance program where if the insurance covers it, it's typically free for the patient. The copay is covered. If the insurance isn't covered, you still get a free trial for that patient. So we want to make sure patients have the opportunity to try the product and really have the benefit. And then from there, we've launched Saliva Cane, which is kind of also helping with that pain issue that we just spoke about. Saliva Cane gives us the option to treat the patient's pain. So it's Saliva Max with a 5% benzocaine in it. And it gives those patients that just finished surgery or post-treatment or whatever it may be, it gives them 30-minute relief from swishing with a 5% benzocaine so they can now eat or drink for 30 minutes. And then they kind of course, the pain always comes back. So Saliva-Cane gives patient temporary pain relief, while Saliva Max is helping treat those patients. So it's not one or the other. The options for Saliva-Cane always come with the Saliva Max. For everybody that typically, say you have an aphthous ulcer, which is by definition mucositis, patients that have aphthous ulcers, you need to treat the aphthous ulcer, which is where Saliva Max treats that mucositis, but also they have pain associated with it. Saliva-Cane helps treat that pain while the Saliva Max is still being taken to treat the actual lesion. So that's kind of where we've had success, is really educating offices on the benefits behind other options that are on the market besides, the current things, that over-the-counter options that we know may be acidic, and they also may not be working as much as we'd like them to be. I'll end with this, and I know we have a few more minutes left, but I'll end with a personal story of mine. So this is my grandmother. My grandmother was diagnosed with lung cancer at the age of around 82. Which was 2 years ago. And this is my wife and my little one, one of my little ones. I have a 6-week-old now, so sleep is awesome, as you all can probably imagine. So this is my grandmother diagnosed with lung cancer. And for her, she's typically, one of these crazy stories, that lung cancer that never smoked a day in her life, which is, one of the unfortunate stories. But she was diagnosed with lung cancer, and she was fighting the battle. And unfortunately, cancer metastasized and started growing throughout her body. So we went back to New Orleans, my wife and I, during the holidays. As you can tell, it's a Christmas holiday, and she's asking questions, and I'm asking her questions about what symptoms is she having, and what complications. And one of the things she talked about was having to take so many different medications that at the end of the night, she can't swallow her pills. So she has to find a way to get her pills down to be able to swallow them. There's 7 pills every 2 or 3 hours. And so I said, Mama, you have dry mouth issues, so why don't you try Saliva Max? And for every patient, it's different. The hard thing is everybody wants one patient to say it's 3 rinses a day, and that's works for everybody, and that's not the case. So for her, she tried Saliva Max 3 times a day and for 3 or 4 days in a row, because it takes a few days to work, and it didn't work. So she sent me an emoji text, which is awesome, that she texted me and said, Rob, thanks, but it didn't work. And I called her and said, look, Mama, just try a few more rinses per day and let me know what it works. And 5 was her number. And I share this story because my grandmother rinsed 5 times a day with Saliva Max. And what it did for her is it allowed her not to have to butter her pills at night. So this is a visual that, is unfortunate that somebody had to live through this, but my grandmother had to butter her pills at night because of her xerostomia issue. We're not sure if it's because of her chemotherapy or because of how many multiple medications she's on. We'll never know that probably, but the fact that she had to butter her pills every single night is the concern. And I'm thankful that Saliva Max gave her the option not to have to do that. So again, it's a great benefit to patients. We've seen tremendous results from cancer patients all the way down to regular open mouth sleepers, sleep apnea type patients. Any type of xerostomia is something that patients don't want to deal with, and we're able to help with that as well. So that's it. That's the last story I'll share with you guys. This is our personal information. If you guys ever want to follow us, for every 500 likes on our Facebook page, we donate a device to a nonprofit. So that's our way to give back. Plus, we continue to educate the dental and really medical facilities. So we'd love for you to follow us on Facebook. This is some more information, but you can always go to forwardscience.com if you have other questions. I appreciate the time and the opportunity to spend some time with everybody tonight. I know it's Thursday night. For Danny and the AIM Dental Marketing team, the fact that you guys are doing these webinar series, we love education. I'm an engineer, which means I love education, probably too much. So I appreciate the opportunity to talk to a great crowd and be here for a great audience. This is our special offer for your group and for this group only. So if you all want to write this down, and I'm sure they'll send it out later on, but you guys call in and talk to Leela at our home office, or really call anybody at our home office, but Leela specifically, mention that Practice Perfection sent you over. We have the option for you to try Oral ID or even Saliva Max at a free no-risk trial. We want everybody to experience the option to use advanced technology, because once you start incorporating this technology, it changes the way you see your patients, and hopefully for all of us to combine together to change these trends, because these trends, unfortunately, are going in the wrong direction. So again, thanks everybody for the time, the efforts. I apologize for talking very fast. I'm from New Orleans, so I tend to talk fast, but hopefully everybody understood, and it was a good course. So thanks again.
Everything is relative, my friend. First of all, I applaud you for getting through so much material in the time allowed, and I didn't really feel that you spoke too fast. For those who may disagree, of course, we have recorded the webcast, and you'll be given an opportunity to listen again. But I thought it was great, very educational. Your commitment to never-ending improvement and learning is self-evident, and you know, I'm sure you would agree you can never have too much education. So
never.
I appreciate. Yep. And I want to thank you too for the offer. That's very generous. Also, it really does provide our attendees to find out what your offering can do for their practice and their patients without risk. And I really appreciate you going through the science and the stats too, because I was struck particularly by the fact that, you know, other cancer rates are falling. We're not doing so well with oral cancer, and that almost really is not just an opportunity, but I feel like it's an obligation on the part of our profession to do this. And obviously, it's a little uncomfortable at first, but you shared that you offer marketing assistance, and of course, my company offers coaching for anybody who wants to broach this subject in a way that the recipient, that is your patient, doesn't shoot the messenger, because none of us wants to be the bearer of bad news, and in the overwhelming majority of cases you won't be. But even the bad news is good news if you get it to people early, because you've shown very graphically what in this case especially early identification and then diagnosis and treatment can do for somebody. It's all about quality, not just longevity, but quality of life. So thank you again. And in the time where we did get quite a few questions, so we always have a attentive and engaged audience. So let's just dive in, get through as many of these as we can. And if you submitted a question and we don't get to it, Rob will definitely follow up with you offline, because in addition to what we send to Rob so that he can follow up on requests, we include the questions that everybody asks. All right, so with that, let's start right in. Well, you kind of touched on this, but it was a little bit later. What is the false positive rate of this technology? I think you said there really is none, but why don't you elaborate a little bit?
Yeah, I mean, one of the hardest things that we always try to answer is that question. You know, by definition, the false positive rate means you're detecting something, and you know, these devices are not detection devices, so there really isn't a false positive rate. I think the hard thing is a lot of scientific studies are trying to prove of, you know, well, if they were detection devices, you know, how effective are they? So again, we're already making the assumption that's not really accurate. They're similar to your loops. If you have prescriptive eyewear, there's no false positive rate of those loops. They just help you see lesions better. But you know, again, these technologies are going to show you anything abnormal. Now, I'll stress that everything abnormal, everything dark, doesn't mean it's cancer. So making sure that you understand the protocol, understand the 2-week follow-up, that's really how you truly comprehend this technology. It's not, you know, looking for a dark spot and thinking it's cancer. That's where we're all going to be in trouble if we go that route. So again, there isn't a false positive rate because this technology doesn't diagnose.
Very good. How much are the testing kits? How much do they cost?
Yeah, a lot of the testing kits that we have are actually, they're free for clinicians. Typically what we see is it's similar to anything else. We offer the testing kits for free. Offices can build the testing kit or for acquiring the cells for the patient, and then the laboratory then bills the patient's insurance for acquiring or for reading those cells. We don't have a big copay at all. I mean, the laboratory insurance covers this because a lot of times it's billed for medical insurance, and no, dental offices don't have to deal with it. The laboratory bills the medical insurance, and then the medical insurance then typically has some sort of copay associated, and they take it with the patient, $15, $20, something simple.
Okay. What is the ADA's stance on this technology? I believe I heard you mention 40 years plus they recommend as candidates for screening. But what else do they have to say in general on this subject and about your protocol in particular, if anything?
Yeah, so the ADA comes out, and what they've done, they actually recently came out with an article in the Journal of American Dental Association saying that these technologies are not useful when you already see a clinically evident lesion, which, again, we agree with. If you see a lesion with with your naked eyes in a white light, you don't need to take these devices out. You already see it. So, unfortunately, the ADA is not always going to be where people look for clinical utility for products or for technology specifically. They came out with that article and it says that these devices have not proven a 20,000 double-blind patient study, which I agree. We don't have enough patients to do it, and if somebody has the money, we'd love to do it with you. So that's kind of the big concern, but at the same time, they feel that their recommendation, which means don't use the devices, is they recommended it with a very low confidence level. So my concern is that nobody ever reads full, 30-page white papers. They just read the abstract, and the abstract is not always right for what advanced technology would be.
Well, it's funny you mentioned that because I just heard Michael Glick, the JADA editor, speak, and that's what he said, which is pretty obvious. But don't be satisfied to read the abstract because you really got to understand how the study was put together and what level of evidence it actually satisfies.
And we have a reply to that to the Journal of American Dental Associations on our website, or they can email me. But again, I think if you look at when I was in 7th grade, I had to write a research paper of why I thought soft drinks were great in a vending machine at our school. So what I do, I read 10 papers and I found one sentence out of each paper that said, this is a great idea. And that's pretty much all that study was it's a summary of 10 other papers that said the technology is advantageous, but used in the correct setting. And they just kind of construed the message differently than we would all like. I always say, if your loved one is sitting in the chair, if my wife's sitting in the chair, I don't care if this thing's 3% accurate. I want all the information so I could save her life. And that's really the way we like to practice.
And how old were you when you did that?
What's that?
How old were you when you did that study?
Oh, 10? When I was in 7th grade, we of course told everybody that.
7th grade?
But they're not a great idea anymore. I know that.
Yeah. Well, I was just wondering if when you went on to school whether you studied or taught that course on how to lie with statistics.
Oh yeah, How to Lie with Statistics is always a great book. It's a fun book to read.
Right. Well, and speaking of definitions, this is important obviously to a lot of people, how do you define excessive alcohol use as a risk factor? And how do you feel about, on a more serious, I think that's a serious question too, but how do you feel about alcohol-based oral rinses?
Yeah, we know that Listerine got themselves in trouble about 10 years ago or 15 years ago now probably. Anytime you swish with a carcinogen, it's a bad idea. Yeah, I don't care what this carcinogen is. If you take alcohol, and the problem is patients feel like it tingles, so it's working. Well, that's true because it's a carcinogen infiltrating your cells. So by definition, anybody that drinks 1 unit a day or more per week is an alcoholic, and there's a lot of people that 2 or 3 glasses of wine a week is that's more than the average person, and that's a high consumption. So if you look at alcohol usage and then tobacco usage, it's a higher risk factor. But if you do alcohol and tobacco together, it's 11 times increase that risk factor. So they have these professional athletes that are playing baseball. Unfortunately, I played baseball, and I'd say that most of these guys are chewing tobacco, but they put tequila in their tobacco, and now you got a recipe for disaster.
Like a speedball. Talk about it. To carry the baseball analogy, I guess it'd be a fastball.
Yeah.
Anyway, that's an interesting definition of an alcoholic, though. More than 1 unit. How do you define a unit?
So that's the hard thing. Somebody drinks light beer, it's not a full unit. So I think it's defined as if you drink an average of 1 unit a day, which you're looking at somebody who just has one long weekend, and you're already there.
Yeah. That's the standard. Some people will tell you that drinking red wine, you can have 1 or 2 drinks a day of red wine, and they hang their hat on the fact that it has resveratrol, which is an anti-inflammatory, but it's probably more than offset by the inflammatory characteristics of the alcohol.
It's just like anything. Water can kill you.
You can get that from other sources.
Yeah.
Yeah. Well, right. It's all in everything in moderation.
Yep.
Any suggestions to relieve radiation ulcers in the back of the throat?
Yeah, that's part of the mucositis thing that we've been successful with. The hard thing for radiation, I haven't been through it, so I can't speak firsthand, of course, but it's one of the most grueling things that's been described to me. So if you talk about a patient going through radiation, and it's a head and neck radiation spot, it's hard. And ulcers of the back of the throat are extremely challenging because it's going to change the way they can eat or drink or even, swallow. So Saliva Max, typically we've seen Saliva Max start 2 weeks prior to treatment. And if a patient can take Saliva Max up to 10 times a day, but really 5 or 6 rinses a day, 2 weeks prior to treatment, we're able to really infiltrate those cells, start replenish those ions right when you start that radiation treatment. We're going to start losing those ions pretty quickly. And now they're going to start causing mucositis. So we've been able to show improvement. It's not going to stop it. It's radiation, and they're designed to kill every cell that's in there, which is the goal. But we've been showing some good success. Plus, being able to gargle with it, saliva cane's been helping alleviate that pain so that patients can eat, and not deal with that pain, because it's hard to deal with that pain and to have that pain long term too.
Yes, I don't know from direct experience either, but I know people, and it's anything we can do to help ameliorate their suffering is as we say, members of the tribe of Mitzvah. Is your offering available in Canada?
Oral ID it is, yes. Saliva Max, we're still working with some of the pharmacies there to be able to get the product into Canada, since it's been on the market for about 2 years. But we're working on it. So, yes, Oral ID, Saliva Max, hopefully it's not too long in the future.
Yeah, hopefully. You mentioned there was a section about marketing. This attendee asks, though, do you offer coaching on how to communicate these delicate issues with our patients?
We do. I think that's the benefit of what you guys do too. AIM Dental Marketing can do that probably in a more rigorous basis than we can. We do have some scripts. We do have some training. We do have some coaching that we can do with the office on how to present to patients. Typically, our office are seeing about a 75% acceptance because we are able to educate. Don't just get the patient to sign a consent form, yes or no, and then you're gone. And we have to actually educate them why they need to get screened, and we are able to do that. That is part of our program.
Begin with why. I'm a smarter person than I said. Is Saliva Max mixed with distilled H2O or tap water? H2O, not HTO. Oh, sorry, I'm talking water. And does it need to be refrigerated after mixing?
It doesn't. So the way Saliva Max works is you mix it with 1 ounce of water. It could be any type of water. Really, we're going for those ions, and the water is just a carrier for us. For us to be able to rinse those cells, though, the way Saliva Max works is you can't put it in the water and then let it sit there for more than 3 minutes, or the chemical ingredients actually effervesce and it becomes inactive. So you take the packets around with you, and they have a 1 ounce vial that we give you. Patients are then able to put up 1 ounce of water with 1 packet, rinse with half of it for 1 minute, spit it out, and the other half for 1 minute and spit it out. So we really want to make it.
Okay, so they're individual doses, and you mix and rinse and use immediately. You basically mix and rinse.
Use as you mix.
Okay, you don't pre-mix. Got
No.
it. Good to know. And this question: how does your technology compare with others in the marketplace? That could take up another lecture, I think.
No, again, this technology has been created by 2 of the largest and top cancer centers in both the United States and Canada. The technology is proven, and it's the same. I'd love to sit here and tell you that our technology is better. It's not. The technology is the exact same technology. What we did was we're the last ones on the market, and we've worked with the other companies in some form or fashion, and we've created a complete program to help you incorporate it, market it, and we put it into a device that's extremely easy to use with no consumables. So, we've heard the concerns, and we built a company around oral wellness and really oral oncology, where some of the other technologies may not have. So that's the short answer of it.
Yeah, well, thank you. Short is sweet. And in general, thanks again for a really informative and entertaining presentation. You certainly taught me a lot about oral cancer. I thought I knew a fair amount, but I know a fair amount more now thanks to you. And I just want to let everybody know that in a few days, you all will receive an email with instructions on how to receive your 1.5 hours of continuing education PACE-approved credit. I ask that you now please mark your calendars for 6:30 p.m. Central Time on Thursday, April 26th. Our very special guest presenter on that date will actually be a returning presenter. But at that date and time, we will be hosting PCI HIPAA's CEO, Jeff Browdy, who will deliver his presentation entitled How to Protect Your Practice and Your Reputation. HIPAA compliance and data breaches are now the top existential risk for your practice. Jeff has assembled a team of experts, including certified risk advisors, customer success specialists, and HIPAA lawyers. His group has been endorsed by the American Association of Oral Maxillofacial Surgeons, as well as the American Osteopathic Association, to help their members navigate HIPAA law and protect patient data. Owing to the rapidity with which HIPAA issues are evolving, we asked Jeff to join us for this update on his 2016 presentation. So whether you attended that or not, it will be time well spent to have you sign up for this important presentation. In the meantime, I want to again thank Robert for a terrific presentation, and of course, thank all of you for your continued commitment to practice perfection. Goodbye, everybody.